KSMQ Health Connections. Local healthcare providers answering your medical questions. This week's topic, colon health.
Good evening and welcome to KSMQ Health Connections, where we connect you to some of the finest minds in the medical field. I'm Ken Stone. Thanks for tuning in. Tonight, we're going to talk about colorectal cancer. It is the third most common cancer in both men and women in the United States. And for years, the American Cancer Society recommended that everyone get screened when they turned 50. But a lot of people ignored that advice. More than 25% of adults between the age of 50 and 75 have never had a test for colorectal cancer. And another 7.1% have been screened, but they haven't gone back as recommended, and so they are not up to date. Now, partly because people don't get screened, colorectal cancer is the second deadliest cancer. The American Cancer Society estimates 50,600 people will die this year from cancer of the colon or cancer of the rectum. And 60% of those deaths could have been prevented with timely screening. That means getting a colonoscopy or some other screening test could have saved 30,000 lives this year. So, what is preventing people from getting screened? For the vast majority, insurance is not an excuse. 85% of people who have never been screened have medical insurance. So, are you one of those people who have never been screened? Or maybe you got screened once, but you haven't gone back? Why have you been putting it off? Give us a call. Tell us why. Even better, call us with your questions you have about colorectal health. That includes not only screening, but questions about surgery. What are the different types of surgery? And how do you and your doctor decide which one is right for you? Our phone number and email address will be on the screen for most of the program. Give us a call, 888-255-0121, or email us at healthconnections@ksmq.org. We have several RNs on the phone taking your calls. One of them is Nathan Hauber. He works at Prairie River Home Care, and he is a recent graduate of Riverland Community College's nursing program right here in Austin. Our RNs are going to be taking your questions, and they're going to pass them on to Dr. Darrin Passer. Dr. Passer is a surgeon at Mayo Clinic Health System. He handles colorectal surgery in addition to other types of surgery. Thanks for taking time. And I'd like to start off with that starting at age 50, because the American Cancer Society just recently said, no, instead of starting at the age of 50, you ought to start at the age of 45. Talk about that.
Well, yes, good point. The age of 45 is, if you look at the website for the American Cancer Society, is what's called a qualified recommendation. And what we've been seeing with history of how things have been coming along, we've been finding more cancers in younger people. And those are more left-sided colon cancers and more rectal cancers. And so data over the past 1 to 2 decades suggests that starting screening at 5 years earlier will catch some more of these younger cancers. There isn't a hard data, meaning a 45-year-old is chosen to get a scope and another one is chosen not to get one, and see what happens.
Yeah, I think I saw 10% of colon cancers and 18% of rectal cancers are for somebody under the age of 50.
Yes, and so I think a good change to the time frame will prevent some of those.
Those numbers have been going up, I understand. Does anybody have any idea why?
Some of it is environmental factors. The risk factors associated with some of that might be diet, maybe the lifestyle changes of some people are more sedentary than others. Dietary concerns of too much meat, barbecued meat is one of the risk factors. Smoking, excessive alcohol use, and some of those things are popping up in younger people.
All right, I believe we have a question already. Nathan, what do you have for us?
We do. Betty from Austin called, and she would like to know, if you have blood in your stool, how do you tell the difference whether it's from hemorrhoids or whether it's cancer or something you need to worry about?
Excellent question. That's a visit to the doctor, and that can be either to the primary care doctor for an initial assessment and a look and a good exam, and then a referral properly to a surgeon or a gastroenterology specialist.
Talk about the other symptoms. What are the symptoms?
Well,
and we're talking about 2 different cancers here. So,
well, we are. Unfortunately, there aren't too many symptoms until they're late symptoms, and things have gone beyond where we'd like them to go. So that's why screening is so important. A symptom of a cancer that is occurring that's later on in process might be blood in the stool. It might be a bowel obstruction. Pain is very seldom a problem. A change in bowel habits, maybe some narrowing of the stools would be a sign that things need to get looked at.
And do you find that people tend not to come to you as soon as they should because they're just like, well, you know, it's sort of, you know, I didn't.
I see that far too often. And
Right.
I see that in the younger people. The younger people have the more advanced cancers when they're found.
All right, I think we have another call from Nathan. What can you tell us?
We do. Don from Rochester calls. He's asking, so what happens to your colon over time with the overuse of laxatives?
Well, we've moved away from some of the bad things that we thought were happening with that. One of the visual things that we'll see in a colonoscopy is there might be some pigmentation or some darkening of the mucosa or the lining of the colon. But as far as functional problems, we don't see those as much, or we don't think that is a problem as much. In fact, some of the recommendations from literature suggest that using a laxative, if needed, is the right thing to do.
All right, so people should not do that saying, ooh, it might increase my chance.
Correct. It's a talk with the doctor, but it should be good.
Let's talk a little bit about some of the screening options. I mean, I think a lot of people think colonoscopy. They think, you know, so talk about the colonoscopy,
Okay.
but there are
Right.
other options.
There are other options, and the reason that the colonoscopy is that it's the most used option is that it's still, for the most part, considered the gold standard. It's what other things that are invented are compared to. And so, if people don't want to have a colonoscopy and they have worries for one reason or another not to, there are so many other good options. There are the stool-based tests where we look for certain things. Most of those are done through kits that are sent to the patient's home or picked up at the lab and taken home.
There was a new kit out, just came out a couple of years ago. Actually, Mayo is involved in the research of it. And so, do you find people are like way more likely to do that as opposed to?
I have noticed that, yes. If I can say the brand name is Cologuard, and you'll see the ads for it on TV. It combines 3 different tests. It's looking for blood that is lost only in the colon, and that's better than some of the other tests that would pick up blood from, say, a bloody nose that was swallowed, or even eating too much red meat would sometimes make some of the older tests positive. It also picks up DNA that would be shed or lost from a colon polyp or from a colon cancer.
Okay, so it's still not as reliable, is that right, as a colonoscopy?
It has very high specificity and sensitivity, meaning it has a good rate of picking up when there are problems, but also it limits the false positives. And so it's not missing many things either. It's not missing or giving us false information. So it's a great screening tool to get someone to come in then for the colonoscopy, because that's the follow-up after that's positive.
A virtual colonoscopy. What the heck is that?
Well, that is a test done through the radiology department. It's a CT scan. And the benefits of doing that is it's fairly sensitive in picking up larger polyps or even cancers. The downfalls of that is a bowel prep is necessary to clean out the colon. And then if something is seen, then the person needs to get a colonoscopy.
Sigmoidoscopy.
Sigmoidoscopy alone is not one of the recommended screening tests, but sigmoidoscopy with one of the stool-based tests is allowable.
Because from what I understand, the sigmoidoscopy only goes to the part of the colon which is apparently called the sigmoid, and then it doesn't go all the way.
Correct. It goes about roughly a third of the way through the colon, up towards where it turns by the spleen. And those are great tests if that's what we get people in to do. Younger people, like I said earlier, get the left-sided or the colon cancers in the lower part of the colon. But as people get older, there's more right-sided or far-in cancers.
Okay, I heard Nathan on the phone. Nathan, you got a call for us?
I do. So someone from Faribault called, and she had a question. She's 88 years old. She has a history of lymphocytic colitis. Her last colonoscopy was 5 years ago, and apparently it was an ordeal. It was quite difficult. And she also said that she has a father who died of colon cancer at age 93. She's wondering if she should go back, how important it is to have that colonoscopy done again at her age.
Now, you can't give a diagnosis for a specific person
No.
right over the air, but in general, what about
In
that?
general, I would, if I was seeing her in clinic, I would tell her that she has some good things going for her. One, the lymphocytic colitis is not a precursor to any cancer, and that her dad was older when he had his problem, suggests that she is on a routine screening pattern, meaning every 10 years, to be honest. And so she's had one 5 years ago, she's probably doing okay.
Well, and my understanding was that at a certain age, you stop recommending that people get colonoscopies.
Yes, sir. Generally, the guidelines suggest about age 75. Some people...
And why is that?
Well, if everything's been normal.
Yeah,
Okay.
why is that?
Because the chances, if you've had 2 or 3 normal colonoscopies, the chance that something's going to come up at that age are a little bit lower. However, as people are living longer, there's talk of increasing that screening age, because if you're 75 years old and you have another good 15, 20 years in you, you've had polyps previously, or there's a family history or something, then it's probably okay to continue screening.
All right. If you just joined us, this is KSMQ Health Connections. Every week we bring in experts from Mayo Clinic Health System to answer your questions about health. Our phone number and email address are on the bottom of the screen for most of the show. Dr. Darrin Passer, a surgeon at Mayo Clinic Health System, is here to answer your questions. So, yes, please do call us or just email us your questions. Taking a look at that graphic just a moment ago, it says if you have a family history of having colorectal cancer, 2 to 3 more times likely to get. However, most people who get colorectal cancer never had a family history.
Correct.
Could you sort of explain that?
Well, there's a little bit of a difference between the family history of the people that have that other 25% that have the true genetic, familial, or hereditary genetic deficiencies. About 4% of people will be diagnosed or could get colon cancer. And so if you do that 2 to 3 times multiplying, that gets you in that 8 to 12% range of potential risk. And so while it sounds that 2 to 3% or 2 to 3 times sounds like a lot, in actuality it isn't, but that's what screening's for, is to keep track of those people.
Right. So do you often have people say, well, the reason I never came in is because I don't have a family history of it? And how I'm surprised?
I do hear that. I do hear that a lot. It's a little bit higher risk in first-degree relatives. So a mother, a father, a sibling, a full sibling, or even a child to some extent having colon cancer, those people are at higher risk, especially if that relative was younger than age 60, roughly.
Let's talk a little bit about the different stages. I think a lot of people sort of understand stage 1, not so bad, stage 4, really bad.
Correct.
Just talk in general about when you tend to see patients. Do you tend to get them when they're at stage 1, or do you see them later?
Well, yeah, I think there's a good combination of seeing most people stage 1, 2, and maybe even 3. Stage 1 meaning it's a small cancer. It hasn't invaded too many of the layers of the colon going from inside to outside. Stage 2 is a deeper colon cancer. Then stage 3 we start to get lymph node involvement. And so I do see some of those that have lymph node involvement, but sometimes we don't know that until after surgery. A stage 4 generally is invasion into nearby organs or spread or metastases to other organs.
All right. I believe we have a question from a viewer.
I do. A gentleman from Albert Lee called in. He's 70 years old, has a family history of colon cancer. He's had 2 brothers die from it. He gets screened. He gets a colonoscopy every year for the last 5 years. Years 1 through 4, he said he had 6 to 8 polyps removed each time. This last year, he had 24 polyps removed. He's wondering if he should be screened more often than once a year.
Well, not knowing the specifics of why he's having so many polyps, probably he's getting good intervals. He may benefit from a genetics counseling visit, one of the genetics clinics in Rochester, just to see if there's some sort of syndromic or familial problem that may need to be addressed a little bit more closely. The growth from a polyp to a cancer is a slow process. And that's why we can afford that screening of 10 years when people don't have anything. And so it takes several years for something to turn into a cancer.
So that's the good news.
That is the good news.
So let's talk about risk factors. I understand race is a risk factor.
It is. African Americans tend to have more colon cancers than whites do in this country. In Minnesota, American Indians actually tend to have more colon cancer or have the most percentage. Some of that has to do with might be a smoking risk in the southern parts of the states. Could be a little bit of lifestyle and diet in particular.
I understand diabetes, obesity, also risk factors.
Diabetes is thought to be potentially, I don't think it's really a hard and true risk factor. Obesity, which probably stems from a sedentary lifestyle, I think is more of a risk factor.
Let's talk a little bit, we've been talking a lot about, I think, colon cancer. Let's talk about rectal cancer. Exactly what is it, and what are your options once you find that there's a cancer?
Well, the rectum is just a different anatomical portion. Really, it's the end of the colon before the end. It's different, and it's a few of the genetics are different, but mostly it's the location that changes things as far as the treatment. Some smaller rectal cancers can be removed very minimally invasively, but a lot of times because of the fixed nature of the rectum, meaning it doesn't move around like the colon does to squeeze things through, it's fixed, and so there's things next to it that get into trouble a little bit quicker. But sometimes the treatment is even different in the sense that people might get some chemotherapy and radiation ahead of time before surgery to remove it.
All right, we have another viewer question. Nathan.
Yes. Martha from Austin called in. She asked, what are the signs and symptoms of irritable bowel syndrome, and how do you get it?
Oh, that could be a whole nother show. Irritable bowel syndrome is it's a diagnosis, we say, of exclusion. So people may have a constipation predominant or a diarrhea predominant irritable bowel, and or some people have a mixed. And so abdominal bloating, discomfort, pain, alternating bowel habits, certain foods bothering more than others could lead to that diagnosis. But people are evaluated, making sure they don't have colon cancer or some other more worrisome troubles, and then we work on treating the symptoms of an irritable bowel.
Yeah, and is irritable bowel a precursor sometimes too?
It is not. It is not. I think people sometimes you see the IBS acronym and get it a little bit mixed up with the IBD, the inflammatory bowel disease, which is a precursor.
Which is, okay, and now that you brought that up, and what's that?
Well, there's two main ones. There's ulcerative colitis and Crohn's disease, or Crohn's colitis. Crohn's disease can occur anywhere from the mouth all the way to the anus, but you could certainly include the colon. And those are an autoimmune disease, for lack of a better term, of inflammation in the colon, where there's just high turnover of the lining or the mucosa of the colon. And so all those new cells that have to regenerate, there's just more potential for one of the problems to happen in a polyp form. And so those people just need to be watched sooner and more often.
All right. We have a bit more than 5 minutes to go. There is still time for you to give us a call with your questions about colorectal cancer. Dr. Darrin Passer from Mayo Clinic Health System is here to provide some expertise. Our number, 888-255-0121, and you can email us as well. Our address, healthconnections@ksmq.org. those numbers for, detection early versus detection late?
It makes such a big difference, and that's why we want to get people in. And one of the nicest things I hear is when that first person that comes in, age 55, 56, and their spouse or their doctor finally gets them to come in, and then at the end they'll say, "Oh, that wasn't that bad." And then we tell them to go tell their friends, get them to come in. And another thing we sometimes tell people is that our clinic's a lot nicer to visit than the oncology clinic.
All right. I believe we have another question. Nathan.
We do. We had a caller from Northeast Iowa. She's asking, she's trying to decide between the Cologuard screening and a colonoscopy. She said 11 years ago she had several benign tumors removed from her. 5 years ago she had a clean colonoscopy, and then she had a family member, her mother, at 89 years old, had a resection of part of her colon. She's just trying to decide, should she go with the colonoscopy or the Cologuard?
Okay. Well, she's probably a candidate for both, and not knowing the full details. Generally, the idea is if you've had polyps, that the Cologuard shouldn't probably be the next screening exam. But if she says she's had a clean colon in between, then a Cologuard is probably appropriate. Her mother's age and presentation is probably not so much a concern for her.
All right, talk a little bit about surgery. What are the options if you find a colon cancer? What do you do?
We get it out. Certainly if it's small enough and the patient's a good surgical candidate and things that haven't spread. So there's a big difference between cancer that's spread to another organ versus not. For instance, now if cancer is spread to the liver and it's a small enough spread, that can be resected at the same time as that the main colon cancer is removed. So most operations are done laparoscopically or minimally invasive.
Laparoscopically
yes, meaning a camera and small instruments is what I tell patients. So it's a major surgery still. It's a general anesthetic, but we can get most of that done with a camera and a small instruments, and it minimizes their recovery time, and the outcomes are just as good.
All right, I believe we have another question. No, we do not have another question.
Oh, no.
Sorry, Nathan's
That's
on the
all
phone
right.
right now. We'll get to him in a second. So let's talk about complications. After surgery, there can be complications sometime.
Yes.
How often does it happen, and what are they?
Overall, it's about a 5% complication rate, and that can range from a serious problem with the portions of the colon or bowel that we put back together, up to something a bit more minor, which might be the wound troubles. Any surgery carries risks of heart or lung or blood clot risks, but those are minimized as best as possible for surgery. With good surgical technique, we can get people through fairly well.
For recovery, what should people know? Let's say I'm going to have some sort of surgery. Let's say I'm stage 1. Am I on my feet for 2 weeks, 2 months?
Well, it'd be usually a 2 or 3 night stay in the hospital. Then you go home. And I tell most people with any operation, plan for up to 2 months before you feel like I haven't had an operation. But with minimally invasive or laparoscopic techniques, most people are getting back to doing most things they want to do in 4 to 6 weeks.
Okay. Talk a little bit about the future. What are some of the new techniques or new research telling us? Is it good news?
Well, I think it is. I think the refining of the tests for screening will get better. The biggest complaint, or the most common complaint I get, is, isn't there something better to drink? And the most important part of the colonoscopy is getting cleaned out well enough so that I can see. And so any of the surgeons that are doing that can see what we're looking for. There have been attempts at making that better, but those were harmful to people in other ways, and so those were taken off the market. A lot of the genetics is probably going to be the next step, where people are identifying who is the best person to screen and who to follow at certain intervals. Because if we can narrow down who to screen, and that's the advantage of a Cologuard or some of the other stool-based tests, is those are the ones that need colonoscopies more than maybe someone who doesn't have a positive test.
And do we have time for one more question? We do. Very quickly.
We had a caller call in. He said he's been to the emergency room, told that he has a GI bleed. But he doesn't have anybody to drive him back after a procedure if he's medicated. So he's wondering about the other options like a virtual colonoscopy or simply not having medication during the procedure.
And you have about 20 seconds to answer.
I guess offhand I wouldn't offer the virtual for someone who's actually having bleeding seen. But yes, we can offer a procedure without sedation, so he could go home on his own. But we'd have to have a little talk ahead of time.
All right, sounds really good. That is all the time we have for tonight. Our thanks to Dr. Darrin Passer from Mayo Clinic Health System. Thanks to the RNs for handling the calls and the emails, and thank you for joining us. Next week, our topic is osteoporosis. Now, you might think it's something you don't have to worry about, but 1 in 4 women over the age of 65 get it, and men also suffer from osteoporosis. You can email us your questions right now if you like, or you can give us a call live next Tuesday night. Hope to see you then.